Good evening, everyone. At the outset, I would like to thank the organizers for giving me this opportunity to present about nephrotic syndrome, which is one of the major renal disorder in children. The other one is Bsc.N or post-streptococcal glomerulonephritis. So I'm here to talk about nephrotic syndrome. Nephrotic syndrome is a renal disorder where there is damage to the glomeruli matter. We know that glomeruli matter is the one which is essential for filtering the solutes, especially the major ones like albumin. And when there is a damage to the glomeruli matter, then definitely there will be escape of protein and the albumin into the urine, and that causes various pathological changes. So nephrotic syndrome, it is characterized by four important features. One is massive proteinuria. Because of the damage to the glomeruli matter, protein seeps into the urine, and there will be more than 3.5 grams of protein in 24 hours urine. And the second major feature is marked hypoalbuminemia. Because the protein escapes into the urine, there will be less amount of albumin in the blood, and albumin is the one which is responsible for keeping the oncotic pressure within the blood vessel. So it will be usually less than 2 milligrams per deciliter, and so therefore these children present with anasarca. Anasarca is nothing but the fluids from the intravascular system, they seep into the interstitial space, and that causes edema all over the body, and that's mainly because of the less albumin which is present within the blood vessel. And the third important feature is hypercholesteremia. We know that in the blood, the lipids and the protein, they are together in the form of lipoproteins. When there is hypoalbuminemia, then there will be large amount of free-floating lipids, which causes hyperlipidemia. So these are the four major characteristic features in nephrotic syndrome. And causes as such, actually majority of them, almost 80 to 85% of them present with idiopathic type, which is actually having a very excellent prognosis because they respond to steroid therapy. They are able to respond to prednisolone therapy. And idiopathic means the cause is unknown. And the secondary causes are Bsc.N. Children who have had post-streptococcal glomerulonephritis, they can present with nephrotic syndrome, or diseases like malaria, syphilis. Post-disease, they can develop a nephrotic syndrome. Or even long-term drugs like penicillamine or sulfonamides usage, and even lymphoproliferative disorders like ALL or any kind of lymphoproliferative disorders, and anything which affects the blood vessels like atherosclerosis, and autoimmune disorders like SLE, polyarthritis nodosa, all these also can, and even heavy metals for that matter, heavy metals like gold, lead, mercury, and things like that. I remember one of the children who came, she is a child from a gypsy background, and they used to make beads, and this child has the habit of putting the beads in the mouth, and from that the child sustained lead poisoning, and therefore child landed up here with nephrotic syndrome. So heavy metals can also cause nephrotic syndrome in a child. So these are the different causes for nephrotic syndrome. And actually secondary type accounts for 10 to 15%, idiopathic accounts for 80 to 85%, and the last type is congenital type, which is very rare. If we see a child less than 2 years of age, that most likely it is congenital type, and for which the prognosis is not favorable. And so we saw the definition, we saw the major classification or the causes and signs and symptoms. The child will have BP, hypertension, not all of them, maybe 50% of them may present with hypertension, and because of the fluid, and also there will be anasarca or overall generalized edema. There will also be massive proteinuria and marked hypoalbuminemia. And they may present with breathlessness if they land up with CCF, congestive cardiac failure. And majority of the children develop this between 3 to 7 years of age, and the peak incidence is from 3 to 5 years of age. Management, it involves medical therapy, which is mainly prednisolone. They start with the 2 mg of prednisolone per kg body weight, and over 4 weeks, and then the next month, 4 more weeks, they taper it down to 1.5 mg per kg per day. And in case child is not responding to prednisolone therapy, then they look for alternative agents like methylprednisolone or chlorambucil and so on. And so majority of them respond to the 2 months prednisolone therapy, and in case they become steroid resistant type or steroid dependent type, then it may be a long course of predni therapy. It's not for 2 months, it may exceed even to 6 months and 1 year or even 2 years. And besides the medication, and also they will be put on antihypertensive drugs if they are presenting with hypertension, and diuretics when they have edema. Diuretics like Lasix 1 to 3 mg per kg body weight. And the second mode of treatment is immunosuppressants. These children also are put on immunosuppressants like cyclophosphamide. And besides that, dietary management. Some decades ago, they used to be put on high protein diet and various restrictions, but now the present trend is that they are put on normal diet, but if there are any derangements in the sodium and potassium levels, then probably their sodium and potassium need to be restricted. And we know the common food items which are rich in sodium, like pickles, puppets, and all dietary products, dairy products, and also tender coconut water. And potassium, which is high in fruits and fruit juices, ice cream, vanilla products, and cakes, and all those kind of dairy products. So all these need to be controlled or even minimized. And the sodium restriction, they may put on 2 grams per day or even 1 gram per day depending on the sodium level. So otherwise, if the levels are normal, probably the child is on normal diet, but definitely there is a kind of check on the fluid. If there is a fluid overload, then they may restrict on the fluids. Previous days intake plus output plus 600 ml if it is summer, and plus 400 ml if it is winter. And the other main mode of management is infection control, because these children are on prednisolone therapy for 2 months or even more, and